like we talked about earlier in our prior kinesiotaping session, there's a lot of research out there that doesn't prove one way or another about what kinesiotape does. So a lot of the studies that are coming out more are validating more with blood flow, with what it does with pain management, that kind of thing. So kind of mentioned earlier, we're doing a study at Tulane on a particular taping technique that we feel is going to unload the rotator cuff, okay? Two ways. One, it's going to put the scapula in a better position, so the rotator cuff has a better mechanical advantage to contract. And secondly, we think we're getting a decrease in linear load to the rotator cuff just from the weight of the arm. When we do this technique on anyone who's any type of rotator cuff pain, we know we get a decrease in pain. Why is that decrease in pain happening? It could be placebo effect, it could be just tactile input from the skin, a lot of different things, but we're really thinking this technique, we're actually getting a decrease in linear load to the rotator cuff. So, and we got pre-cut pieces depending on the size of the athlete. This is actually the technique we're doing with our baseball players at Tulane. So our pitcher will go and he will do 80 plus pitches, 60 to 80 pitches in an outing. They're going to go through their full recovery program, and then we're going to tape their shoulder in a way for 24 hours after the outing. We know that with the load that happens with pitching, we get an increase in inflammation in the subacromial space. We're going to get supraspinatus going to be irritated. We think that if they go home unloaded, chance of them laying on the shoulder is going to be decreased. Chance of just the linear load to their shoulder is going to be decreased. And I mean, these guys are students, so they're wearing backpacks, all the other good stuff. We kind of think that all contributes to the problem. So first things first, we're going to take her. We're going to put her kind of what we think is in a neutral shoulder position. So I don't want her full retraction. Okay, I want to come back about 10–15% from where she likes to be. We're going to use the AC joint, and that old scar is an area that we're going to go after. Okay, so no tension on the tape towards the AC joint. I'm going to take the tape, and I'm going to put 50% tension. Okay, so there's my indicator, 50% tension down. I'm going to lay it down to there and finish there. So now I've got 50% tension on the tape, okay? I'm having retraction, I just relax, okay? So it's a subtle input. I don't want this huge thing, it's subtle, okay? I'm gonna take her now, I'm gonna put her in the plane of the scapula, okay? Here, I'm gonna use C7 as kind of our area that we're gonna go after, okay? So we're gonna come here. Where we're gonna come in. C7. Come underneath the sports bra. Okay, so now I'm going to use the back of the deltoid as my area. I'm going to put 50% tension on and finish right there on the deltoid insertion, okay? I'm going to do the same thing again, okay? But I'm going to go around the front side now. Okay, so I'm going to come here, crossing my tape, coming around front, and then finishing on the deltoid insertion, and then she goes back down. As soon as she goes back down, she gets kind of a linear decrease in the load to the shoulder when she's kind of down by her side, okay? She's gonna stay that way for 24 hours. We usually cut a big I and a big Y, but just for the demo, we have these pre-cut pieces. So that's one thing. Anyone with rotator cuff tendinopathy, anyone with shoulder pain, I promise you put this on them and they feel much better. Multi-directional stability, the female athlete, this helps a ton. Just teaching them where their shoulder is in space. Let's talk a little bit about Tommy John reconstructions. Most of my clients who come off of Tommy John reconstruction return to pitching end up with chronic mid-belly bicep tendinopathy. They always have biceps pain, okay? And they'll have recurrent elbow pain, feeling, oh my God, it's the Tommy John again. And it's not. Or we end up with a slap lesion because they end up, deceleration of the arm becomes hypersensitive for the bicep. The brain, even though we fixed it, still thinks that the UCL is gone. So we've been doing preventative taping and taping during the game to decrease the tension on the bicep. So you can come sit right here. All right, so we're going to put her in a speeds test position, okay? I'm going to take the tape, going to find kind of the AC joint, and I'm taping over my original tape job just for, so I'm here, break. I'm going to come down, and I'm going to go medial, apply 25% tension. I'm finishing along the distal bicep, okay? And she's going to feel this unload her bicep tendon when she comes down. And I'm just doing different things so that when the player decelerates from throwing, they feel that tension to kind of decrease the amount of tone in the bicep when they release the ball, okay? The other thing we're going to look about is my Tommy Johns. You'll see the incision there. We're done a ton of PRP now instead of reconstructives. If it's a partial tear, they'll do PRP injections, and we're doing kind of a tape job over the UCL to kind of help them with return. So post PRP, they're in a very restrictive brace, so they don't put any tension on it. And then their first few times of throwing, we're going to do kinesiotaping along the medial joint line. And what we do it, just same thing we do with like a medial and a lateral knee. Open up the tape. We're going to apply 50% tension over the UCL, and we finish above and below, okay? You can use nude or the skin color tape. The only issue we've ever had, if an umpire sees it in the arm, we have an issue, so the kids will usually wear sleeves when they do it. It's not an accentuation of their arm, it's something that's going to help protect it, but we think the kinesthetic awareness makes a huge difference with deceleration of the arm. Go. All right, so shoulder, elbow, done. Any questions?
Can you go over the landmarks again for the shoulder?
Turn around. Posterior AC joint, that's where I anchor it. Come down, and if you look at the scapula, I'm kind of bisect the scapula in the middle, and I want to get to T12. Okay, I want to get to T12. What we also have been doing is also taping the contralateral hip in conjunction with the shoulder. So we'll actually put them, lay on your stomach. Let's get all that out of the way. Yeah. There you go. So this is kind of a little bit out of the box, but we're going to take this knee and bend it. Bend the knee here, okay? This hand and your groin, left groin, your other groin. So we'll actually put them in this position here. So think about it. She's in crawl position, but when I release a pitch, I'm in kind of a crawl position. So I have hip instability here after rotator cuff tendinopathy, after rotator cuff surgery, after Tommy John, my contralateral hip becomes weak. If I don't stimulate that glute, I'm gonna miss something here. So we'll actually tape her from here towards the opposite scapula and stimulate the left glute along with the right arm so that when my pitcher goes and throws, they feel that tension and it wakes up the glute to absorb the front side load. When they're pitching, the front side hip has to be a stiff, basically a very stiff plant leg. They can't absorb because they're going to lose energy. So it's got to be a restrictive, stiff plant leg, and we want to make sure that front side hip is as strong as possible. All comes back to gait, all comes back to developmental kinesiology, how we move, okay? So instead of taping, we used to tape our lumbar patients in standing, we go here to here. Why not tape contralaterally from hip to quadratus femorum? So glute to QL, glute to QL. So we'll use bigger pieces, of course, and we'll go mid-belly across. I'll swap her, and we'll go mid-belly across. So she'll crawl one direction and the other direction. Good. Cool. Thank you, guys.